We'll be talking about the concept of mobility. As we go through our content, you will have your learning outcomes. You can pause the video to look over them. We will continue with our musculoskeletal system with muscles, tendons, bones, ligaments, cartilage, and joints. They help to support the body weight, control movements, provide stability, provide protection for vital organs, and allow for movement. Remember with bones store nutrients. They help to produce white blood cells and red blood cells. Remember we talked about bone marrow and what bone marrow does, helps to produce those white blood cells. Red blood cells are platelets. Bones are highly vascular. That means they're going to bleed if they get broken, for example, in a fracture. The blood provides oxygen, calcium, and other nutrients to strengthen the bones and transports electrolytes needed for muscle movement. Nerves innervate the muscles to provide the electrical stimulus needed to innervate contractions. So we have a whole bunch of different things going on. We need a nerve impulse in order to stimulate a muscle contraction in order to make our skeletal body move, right? So all those have to work together, and we also have to have blood supply and electrolytes to be able to make things move. Musculoskeletal system, you can read over this slide and pause it if you need to. Alterations in mobility include fractures that we're going to be talking about, a break in the continuity of bone. Could be caused by a fall, blunt trauma, motor vehicle accident, abuse, repetitive force, lots of different reasons. Multiple sclerosis is an autoimmune disorder. We talked about in immunity. It destroys the myelin sheath around the nerves, disrupts transmission of the nerve impulses, and it impairs the brain's ability to communicate with the rest of the body. There's sensory and motor disturbances and alterations in bowel and bladder control in multiple sclerosis. So let's think about that for a minute. The myelin sheath is destroyed. Nerve disruption of those transmission of those nerve impulses. So if we have a nerve impulse that's disruptive, we're going to have an alteration in mobility, remembering that we need those nerve impulses to make muscles move in order to make those bones, our skeletal muscles, our skeletal bones move so we can actually walk. Parkinson's disease is a central nervous system disorder that is caused by a degeneration of several areas of the brain that produces the neurotransmitter dopamine, accompanied by normal levels of acetylcholine produced by the neurons. So it is a neurotransmitter. Dopamine is going to stand out for you, as well as acetylcholine when we talk about these different disease processes as Parkinson's disease. Continuing on to the next slide, I have spinal cord injuries listed here, medical emergency that may result in permanent disability or even paralysis. This can be because of a motor vehicle accident, assault, gunshot wound, sports injury, fall. Cervical injury. So when we talk about spinal cord injuries, we're talking about cervical, thoracic, we're talking about lumbar, we're also talking about sacral. So anywhere in the spinal column. So remember, if you have a cervical injury, we have C1 through C3 that controls our respiratory drive. If something happens there, we lose our respiratory drive. We can't breathe, and so we end up on a ventilator, right? Mechanical ventilation. Now, if we have C4 or C5 damage, it can also cause us to have breathing problems because the C4 and the C5 connected with all those thoracic, that's basically, if you think about the nerves that innervate that area and we think about the structures in that area, that helps us with our diaphragm to be able to breathe. So if we have a C4, C5 or thoracic injury, that can interfere with our breathing as well. Lumbar is, of course, our movement, but also it is going to be our bowel and our bladder as well with our sacral. So cervical, whenever we have a cervical injury, we're thinking about breathing, neck, shoulders, and the upper extremities. When we think about our lumbar specific, we're thinking lower extremities, bowel, and bladder. I do have multiple sclerosis and Parkinson's on here again for review for you. We'll talk about some more disorders, but I'm going to move on. Bruises, strains, and sprains are traumatic injuries that occur with alterations in mobility. Traumatic injuries cause alterations in mobility. Bruises, ruptured blood vessels, localized pooling of the blood, bruising and tenderness. This is the black and blue that turns into the yellow-green after days. There's also edema that goes along with this. Strains is stretching or tearing of ligaments. There's pain, swelling, bruising. When we look at sprains, there's stretching or tearing of muscle or a tendon, which results in pain, swelling, and muscle spasms. So all of these we treat the same. We price them. We protect, rest, ice, compress, and elevate. Bruises, strains, and sprains, we price them. Protect, rest, ice, compress, and elevate. Continuing on, alterations in mobility, thinking about an amputation. Amputation is partial or total removal of a body part. So we can have a BKA, we can have an AKA. Well, what does that even mean? BKA, below the knee amputation, AKA, above the knee amputation. We can also have upper extremity amputations as well. So an amputation is that partial or total removal of the body part. So maybe somebody had an above the knee amputation because what started out as being a diabetic and having a leg ulcer that wouldn't heal, maybe a wound on the foot that wouldn't heal, turned into a infection that turned into necrotic tissue that turned into gangrene, and they ended up having to have half the foot cut off. That led to having them have a below the knee amputation and all the way up to an above the knee amputation. Also think about circulatory problems like peripheral arterial disease, and they're not getting that blood flow and that blood supply. That could be a reason for an amputation. Lots of different reasons. Could be because of a crush injury. Somebody was working on a car, they had the car up on a jack, and the jack gave way and the car came down and actually landed on their lower extremity and crushed it and severed some of their vessels, and the could not save the lower extremity. Those are reasons for amputations. Amputations have a high risk for bleeding after they have been amputated, so that is why we use a compression dressing. We also need to make sure we have a tourniquet in the room. They can bleed very quickly, very fast, and lose a lot of blood. Make sure you have the tourniquet in the room. Make sure you're checking that dressing. Lift those covers, move that patient, make sure they're not bleeding. Complications after amputation include infection, delayed healing, chronic pain, phantom limb pain, and contractures. Thinking about that phantom limb pain, we use medications to help with the nerves. So medications like Lyrica, pregabalin, or medications like Neurontin, gabapentin. Those help with the nerve part of phantom limb pain. So when we think about our patients, they have pain. Your left leg is gone because it's been amputated above the knee, but yet you're telling me your left lower foot hurts and you're rating it out of 10. What do I do as a nurse? I can try to reposition a patient, yes, but that limb is not there. What do I have to do as a nurse? That pain is real to them. I medicate. Do we use opioid pain medications? Absolutely, yes, 100% we do. We do give hydrocodone for phantom limb pain. Contractures. You might have seen a patient who is a bilateral lower amputee sitting in a wheelchair, and you notice that the residual limb is flexed up on both sides, and you wonder why that happened. Patients who have amputations on the lower extremities need to have prone time. They need to lay on their stomach. They need to have tummy time. It's called prone time. The reason why is we want to prevent those contractures. They don't do it the first day after surgery or the second day after surgery, but while they're in the hospital, we do have prone time for them to prevent those contractures. We teach them that for discharge as well as they continue it with rehab. Notice there's a star about rehab. Rehab, PT, OT is going to be working with these patients for sure. Nursing problems associated with amputation include impaired mobility, risk for infection, acute and chronic pain, and body image disturbance. Remember, this patient is grieving through that loss. Other concepts related to mobility noted in your book include collaboration, comfort, health and wellness and injury, mood and affect, safety, stress, and coping. Continuing on with mobility health promotion, nutrition and exercise are very important. Calcium maintains strong bones and provides ions for muscle contraction and nerve transmission. Need to have calcium in the diet. So those foods that are high in calcium include a lot of our dairy products and also our spinach, our green leafy vegetables. We also need vitamin D. Vitamin D, best source is going to be sunlight. Exercise. Regular exercise stimulates building strength and deposits mineral bone into the bones, maintains flexibility of joints, and prevents worsening of some of our joint disorders. So when we think about modifiable risk factors, of course, it's going to be nutrition because we want to make sure our patient's getting adequate calcium, adequate vitamin D. But when we think about other modifiable risk factors, it is obesity. And with obesity, it's a major factor for mobility problems. Excess weight strains the joints, and cartilage and protective materials are destroyed. So we need to encourage weight loss. Also, we need to encourage that individual for exercise. 30 minutes of walking a day is great exercise. Remember, promotion of mobility begins before birth with the maternal during pregnancy. Mother can take folic acid to help reduce the risk of spina bifida. And mom also needs to have a good high calcium diet while she's pregnant. Mobility nursing assessment cues. So whenever we are looking at a patient, we're looking for anything that would say that, hey, this patient has some altered mobility. So we're going to look at their balance. We're going to look at their gait. We're going to look at the chart and see about weight alterations. We're going to see if they have any assistive device usage. Then we're going to look for pain. When we think about looking for pain and observation, we're looking at facial grimacing, right? Does something, or if the patient is verbally moaning, that could be a sign of pain. If the patient is not able to fully reach their arm out, or actually the patient is using things to help them to move, like they are holding on to tables or chairs whenever they're walking. We'll assess for pain, limited mobility, fatigue, weight changes, inflammation. We can look for swelling, those kind of things. The patient interview, we do the health history. When we look at that, we look at the pain characteristics, lifestyle, occupation, sports, exercise, sedentary or active lifestyle, and their nutrition habits, along with their past injuries, joint pain, and neurological problems, and how it impacts their ADLs. That's very important. As we continue on, we do the physical examination with the range of motion and assessing the 5 Ps of the neurovascular assessment. Make sure you know these, understand these, memorize them, and know how to assess for them in your patients. Moving on, mobility assessment chart. Please make sure that you review that in your textbook with the physical assessment for gait and posture, joint assessment, and range of motion. There's mobility diagnostic tests. These are labs, the alkaline phosphatase, calcium, calcitonin. You can look through all of these, be familiar with them. We'll talk about them more in class time. With our other tests, we can do imaging like bone scan, CT, X-ray. They can also aspirate fluids. We'll talk more about these during class time. As we look into independent interventions for our patient, remember we can provide education, promote comfort, and prevent injury, and foster independence, and of course reduce social isolation. How do we do that? Go ahead and take a pause break, look at what this slide says, go back to your textbook to help you. We'll also talk more in class. Mobility collaborative therapies are listed there for you, so make sure you review them, as well as thinking about more collaborative therapies, pharmacological therapy, including those muscle relaxants, but also non-pharmacological therapies. So looking at this slide, it does talk about the lifespan considerations. Familiarize yourself with this slide as well. That wraps it up for our mobility pre-lecture content. When we come to class, we'll talk more about mobility as a whole.